heart failure can be deadlier than many cancers. It has been seen the chances of 5-year survival in heart failure is around 40 to 50%, whereas the chances of survival with other cancers are still less. So more patients have been found to die of heart failure in 5 years. If you see, the heart failure is progressive with a high mortality, and as the disease progresses, the quality of life become less. They become more suffer from the problem, and the functional class deteriorate, where mortality increases, survival decreases. That's why you see this every 9 out of 10 persons in that we can say 1% of all the patients all the persons above the age of 18 years are suffering from heart failure. If you see, heart failure are at a very high risk of death and hospitalization. 9 out of 10 patients are asymptomatic even with current health guideline status. Nearly 1/3 of the patients with heart failure reduced ejection fraction are at higher risk of hospitalization or severe death, including those who appear stable. They are actually not stable, they are unstable, but they appear to be stable. So 32% of patients with heart failure hospitalization or cardiovascular death. You see, each heart failure hospitalization increases the risk of mortality further. So patients say admitted with heart failure. With that, usually the survival is about 3.6 years. After second attack, 2.6, and gradually decreases 1.8, 1.5, 1.3 years like that. The more the attack rate, more the chances of heart failure hospitalization, more the chances of death. So this is the truth regarding the heart failure hospitalization. So what is the data? Western countries in our countries. What we discussed, that is about the Western countries. But the chances are more here in India. The prognosis is poor, and more of people in India are involved. If you concentrate here in this slide, heart failure appears to be a bigger challenge in India. Why? Globally, the mean age of patients presenting with heart failure is 73, in-hospital mortality around 3 to 4%, post-discharge mortality 6-month mortality is 8.6%. However, in the study, it has been seen in India, the mean age of patient presenting with heart failure is 53, like 20 years before the Western country. And in-hospital mortality is around 38%, 30.8%. Post-discharge mortality at 6 months is 26.3%. Therefore, patients with heart failure in India affected at a younger age have a very high mortality, and both in hospital and also after discharge. So mortality rate is high, hospitalization rate is high, after hospitalization, re-hospitalization and chances of death is high. If you see the heart failure survival rate in inter-CHF study, where 23% of the Indian patients with heart failure die with a year of diagnosis. Here they have compared people from overall and China, Africa, India. If you see, more of patients from Africa and India are younger. Though they are younger, still they have a higher mortality. So despite being the youngest cohort at baseline, the patients with Africa and India had the highest mortality. That is Africa 33.6%, whereas 23.3% in India. In the analysis of cause-specific mortality, it was noted that cardiac death alone, patients in India, the hazard ratio 2.5, were at highest hazard of cardiac death. The survival rate for heart failure are worse than most of the cancer. For example, those who are bowel, breast, and prostate cancer. So, what is the prevalence of India? Heart failure in India, the truth is, there are at least 8 to 10 million patients of heart failure in India. Prevalence is about 1% adult population. Heart failure in India has a post-admission mortality of 20 to 30%. So medication adherence ranges from 25 to 50%. So the adherence of the medication is very important. Only the adherence to the medications, the survival decreases and mortality increases. So adherence to medications in India is around 25 to 50%, but most of the places is around 25%. The age, India has a relatively young population of heart failure. As we saw, the average age at presentation is 53, whereas this study has found the incidence of diabetes in heart failure in Trivandrum heart failure study was 54.9%. Trivandrum heart failure study was found that 54.9 or 55% of patients with heart failure had diabetes. Incidence of hypertension is 42% in patients of hypertension in heart failure is about 42% in India. So we see the key points. Higher mortality and readmission rate in India with heart failure result from Trivandrum heart study. What it shows, 3 out of every 5 patients have died during the 5-year follow-up. So their 5-year data is death rate around 60%. The median survival of approximately 3 years in this young cohort of heart failure patients. Lack of guideline-directed medical treatment in patients with heart failure, reduced ejection fraction, and frequent readmissions are associated with higher 5-year mortality. So most of the patients in India, they do not continue guideline-directed medical therapy and in appropriate dose for the appropriate period. That's why the 5-year mortality is higher in India compared to Western countries. Only 25% of patients were discharged from index hospitalization DDMT. Importantly, prescription of DDMT at discharge but associated with lower 5-year mortality rate in patients heart failure decreases. That means in-hospital mortality due to heart failure in India is high. Interventions aiming at increasing guidance may improve heart failure outcome in India. So we have to emphasize the guidelines directed medical therapy should be provided to all patients with heart failure, and they should be advised to continue these medications so that we will have a better survival, better quality of life in patients with heart failure. What are the goals of heart failure therapy? As we discussed, one, improvement in survival. If you see the reduced mortality or premature death, ideally by reducing 2 main modes of death, that is sudden cardiac death and death from progressive heart failure. So these are the 2 conditions where there is a decrease in death by improvement in survival, and reduce the hospital admission. If the hospital admission is more, the morbidity is more, and the whole family suffer, there is an economic impact on the family. So apart from being very unpleasant for patients, it is distressing for the families and costly. So it is a bad prognostic development, which is also true of any episode of worsening heart failure requiring intensification of therapy. And last but not the least, that is improvement in quality of life. So people should feel better. So he or she should feel better. So improvement in symptom and improvement in quality of life, or at least slow the rate of deterioration. So deterioration rate should be slow. There is improvement of quality of life. Allow people to continue to lead as normal, as unrestricted life as possible. He should not feel that his patient is suffering from restriction of activities, but he should be allowed to have activities along with others. So therefore that you need to improve the quality of life. That is very important. That has an impact on the psychological part of the patient with heart failure. this illusion of stability in heart failure. What we tell stable heart failure, there is nothing like stable heart failure. Heart failure is never stable. At any moment they can be unstable. So 20% of the stable patients where there is no prior heart failure hospitalization in a paradigm HF had a primary event. Primary event means here they decided this is cardiovascular death or heart failure hospitalization. So stable, they were asymptomatic, 20% of them, they had also seen events. 17% died during the course of the trial, though what we consider stable. Of stable patients who experienced a primary event, death preceded heart failure hospitalization 51%. 60% of these deaths were sudden cardiac death. So there is nothing like stable heart failure. So ARNI should be started as early as possible. Do not wait till the deterioration occurs. So it should be started as early as possible. This has been supported by the guidelines, the ACC Heart Failure Society of America guideline for the management of heart failure 2022. What they say? They are very clearly mentioned. You see, the first one, the class of recommendation, level of evidence. If in patients with heart failure with reduced ejection fraction, NYHA class 2 to 3, the use of ARNI is recommended to reduce the morbidity and mortality. They tell ARNI first. Second, when the ARNI is not feasible, or there is a reaction to ARNI or patient is not tolerating ARNI, there is hypertension ARNI, then only you can consider ACE inhibitor. And third, in patients where the ARNI is not feasible and patient is intolerant to ACE inhibitor, in those situations you go for ARB. So they are very clear. Have to give previously what was there, either they were given ACE inhibitor ARB with adequate dose, the patient tolerate, they are continuing. If patient do not tolerate, or patient still become unstable, or patient becomes heart failure increases, they were shifted to ARNI. Now this is simple. You start with ARNI. If ARNI not feasible, go to ACE inhibitor. If ARNI and ACE inhibitor not feasible, go to ARB. So use of ACE inhibitor ARB only when ARNI is not feasible. So in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction in whom ARNI is not feasible, treatment with ACE inhibitor ARB provide high economic value. You see, what we found, the paradigm HF study is a study in patients with chronic heart failure. They are not on acute decompensated heart failure. So what are the evidences in acute decompensated heart failure and when to start? Re-discharge or in the fast follow-up. So after the benefit of patients with acute benefits with chronic heart failure, the scientists and physicians they thought, let us try in patients acute decompensated heart failure, how is the result? In this evidence-based era, without any evidence, the guidelines will not support the use. Not only the physicians will not support it. If you go by the guideline, the chances of side effects, chances of doing harm to the patient is much less. Therefore, the study taken up is this case Pioneer HF study. Pioneer heart failure study. In patients, 881 patients, the patient, those who are hospitalized for acute decompensated heart failure, EF is less than 40%. They are stabilized in the hospital. In the hospital, they are stabilized. Blood pressure remained more than 100 millimeter mercury. There is no increase in IV diuretic dose. There is no IV vasodilator. They were not on iron neutral, so they were considered stabilized. In such patients, pre-discharge during the hospital, they started sacubitril valsartan or enalapril, and at home gradually uptitrated and blinded till 8 weeks. What they found after that? They found there is change in NT-proBNP. The blue line is enalapril, sacubitril valsartan is the red one. So there is if the patients are having raised NT-proBNP decreased by 1 week. At that decrease persisted throughout the study period of 8 weeks. This was statistically significant. cardiovascular death or hospitalization for heart failure is seen, it is also less in patients with sacubital valvular group. The curve started to divert after 2 weeks, however, the significant after 4 weeks of starting the drug. So after 4 weeks, there is significant reduction in mortality in patients with sacubital valvular. So in those patients, even starting in hospital prior to discharge. Here we see the pre-specified subgroup analysis in de novo patients. Non-cardiovascular death, the de novo cardiovascular death is the blue one, de novo, and de novo heart failure is the ARNI, and this is black one is worsening chronic heart failure, this worsening chronic heart failure, yes. So change in NT-proBNP, this part after 8 weeks. They started at 1 week, after 8 weeks, the based on prior history of heart failure treatment and status, you see the sacubital valvular is blue, enalapril is red here. So worsening heart failure or SMARV, all these things they are found to be significant reduction in NT-proBNP. Such improvement in early clinical outcome would be lost in scenario of ARNI pre-treatment. So ACC-AHA 2021 ECDP writing committee, they have told this. So by this is again a change in NT-proBNP and cardiovascular death. This is found to be significant in patients those where ARNI was started. Therefore, what we find, if ARNI can be started pre-discharge in patients with acute decompensated heart failure, and there is reduction in hospitalization, reduction in NT-proBNP has been recorded. Talk of acute decompensated heart failure. Those were the patients, they had heart failure earlier, they are admitted with acute decompensation. Now they are talking in patients with de novo heart failure, hospitalized patients. So this is again in this era of evidence, without study we cannot say anything. There is the global report HF study and prevent study where it was seen 44% had de novo heart failure, here 66% were having de novo heart failure. Further found this sacubital valvular keeps de novo heart failure reduced ejection fraction patients out of hospital and helps them live longer. So if you start in those patients sacubital valvular, they remain out of that, means they did not need hospitalization. So there is significant lower incidence of composite of CV death and heart failure rehospitalization in de novo hospitalized patients with reduced ejection fraction if sacubital valvular started. So first admission, you start sacubital valvular, rehospitalization less and death is less. This is so transition study. Yes, the same it has been seen. It came out European heart failure journal, transition study, where they found the primary endpoint was to assess the tolerability of treatment in the proportion of patients who achieved the target dose of sacubital valvular after 10 weeks of randomization. A reversal of remodeling was noted in this patient. Sacubital valvular improves echocardiographic parameters of heart failure reduced ejection fraction. This is noted in real world scenario. This is also reported in this data study. Here you see there is sacubital valvular improved cardiac remodeling pump function more effectively compared to ARNI in de novo hospitalized patients with heart failure reduced ejection fraction. Here you can see also HF troponin T, high sensitive troponin T, what was effect of sacubital valvular. So significant reduction in high sensitive troponin T concentration with sacubital valvular in de novo hospitalized patients with heart failure. That means not only it improves survival, improves ejection fraction, improves quality of life, it also reduces the myocardial damage. In this study, it was seen the de novo heart failure is deep blue and prior heart failure ejection fraction is light blue. More de novo than prior CHF patients achieved target dose at 10 weeks. So transition study results. First line initiation of sacubitril valsartan in de novo heart failure reduced infection alongside the initiation of other guideline directed therapies is feasible and is associated with a better risk benefit profile than in patients with prior heart failure reduced infection. Early intervention with sacubitril valsartan should be considered to delay the disease progression in patients with de novo heart failure with reduced disease infection. 2021 update of ESC update on heart failure. 2021 update to the 2017 ACC expert consensus decision pathway on optimizing the heart failure treatment was published. But it shows this is also an important slide. If you can concentrate, this gives the treatment algorithm provided by ACCH in 2021. Of course, this is just changed now in 2022. At that time, they told you start ARNI, beta blocker, and MRA is a foundational treatment from the very beginning if the patient is tolerating. So, sacubitril valsartan or ARNI, beta blocker, and MRA. You see here, all three things you can start. And after that, you assess the patient. For patients with eGFR more than 30, if there is, you can give other treatment. If patient still eGFR criteria, SGLT2 inhibitor can be given. If patient remain in heart failure, diuretic further can be given. For persistently symptomatic black patients, hydralazine isosorbide dilated combination can be given. If heart rate remains 70 or more, then evaporating can be given. This is what they told at that time. So clinicians should aim to achieve optimal GDMT within 3 to 6 months of initiation of diagnosis. But the ESC 2021 told ARNI may be considered as a first-line therapy instead of ACE inhibitor ARB in heart failure patients. But ACCHA told in 2022, same thing was told by ESC in 2021. So initiation of ARNI is in hospitalized stable patients with heart failure reduced disease infection, including those who are on ACE inhibitor ARB NAF, is safe and may be considered. This thing is again told by SCCH in 2022. That is this slide we have seen earlier, where SCCH says you go with ARNI. If intolerant to ARNI or ARNI treatment is not feasible, go to ACE inhibitor. If ARNI and ACE inhibitor are not feasible, go to ARB. When to change and what are the doses equal. This is very important practical point. Practical point what I mean, if we are giving ARNI, if previously patient is an ACE inhibitor or then it should be stopped for 36 hours and after that ARNI to be started. Why? Because ACE inhibitor and ARNI combination can have idiosyncratic hypersensitive reaction. That is why after stopping, the patient is an ACE inhibitor, we will have to stop ACE inhibitor at least for 36 hours and after that you start ARNI. And I will advise stop for 2 days, 48 hours and after that you start ARNI. This is very simple, easy to follow, and 36 hours not easy to follow. So patient, this is very important because many patients before they come to us, they shall come to a physician, they are on ACE inhibitor or ARB. If they are on ARB, we need not stop, we can need not wait, we can stop ARB and go for the ARNI. Because ARNI, one part is valsartan, other part is sacubitril. So valsartan is there, that is ARB. But if the patient is an ACE inhibitor like enalapril, ramipril, captopril, in such situation we will stop the ACE inhibitor, wait for 2 days, after that you start ARNI. Select the dose. That means according to blood pressure, you have to select the dose. If the patient's blood pressure is stable, blood pressure is more than 120 millimeters systolic. In such case, we can start with the higher dose and optimize the dose. If the patient blood pressure is between 100 to 110, we can start with low dose and gradually we can uptitrate. Or if it is less than 100, we have to think twice before starting ARNI. And coming to the AC neutral ARV, consider in patients where ARNI administration is not possible. As we discussed, when ARNI administration is not possible, in those cases only AC neutral ARV will give. And evidence-based beta blocker. What do we mean by evidence-based beta blockers? All beta blockers have not been found to have beneficial in patients with heart failure. Only 3 beta blockers have been found to be beneficial. So they are evidence-based beta blockers. They are metoprolol, carvedilol, and bisoprolol. In the trial, they are given ARNI 200 milligram twice daily, and none of the Indian patients ideally achieve this dose. They do not tolerate such a high dose. So in such patients, whether the low dose is beneficial or not, what are the evidences, what the guidelines says. You see, this is where they have compared what is the reason for failure to tolerate ARNI. The most common reason is the red one, which is almost for 50%, is symptomatic hypotension. After, if you uptitrate ARNI, the hypotension is the first possibility where we are not able to achieve the target dose. And second, this red one, that is worsening of renal function. Others are very minimal. So we need to be very careful because this is an agent, it is a hemodynamic effect. So you can reduce the blood pressure. We should be careful when giving starting and uptitrating. If you see here, reason for failing to achieve target, that is again the same thing. About 75% of the reason we fail to achieve the target because the chances of hypotension in patients with ARNI. So when starting ARNI, we should be careful. Start with a low dose, go slow. And most important, you see in these patients, they do have lower blood pressure in the range of 110, 115, 120. In my experience, we have given patients ARNI, those systolic blood pressure 100 or more. And in the next follow-up, when you want to uptitrate, we find such patients having higher blood pressure. Why so? We think it reduces the blood pressure, but not only that, it also improves. It improves myocardial contractility, improves health, reduces the heart failure. Thereby, the improvement in ejection fraction and improvement in blood pressure also. So don't think that if you give coming next time, the patient may feel better. Patient will tell you after starting that medicine, I am feeling better. You will see also there is objective evidence. So start reasonably. Every patient is different. You are seeing the patient. You know what are the comorbidities with him. If patient is already, overloaded with fluid, or patient is dry up, accordingly it can behave differently. So we have to be very open our brain, open our mind. So sacubitril valsartan benefit irrespective of the dose. This is the trial you see, this came in European countries, where this primary outcome measure by means of dose post randomizer. So participants taking lower than target sacubitril valsartan dosage had a lower risk of primary event compared to those taking lower than target dose of enalapril. So they have seen those patients, those who are not tolerating sacubitril valsartan, they are also not tolerating enalapril. But even if they take comparable dose or lower dose, the patient, those who are taking enalapril had a poor outcome, whereas those who are taking sacubitril valsartan had a better outcome. So even if they do not achieve the target dose, with lower dose also they get the benefit. borderline systolic blood pressure, is it helpful? That was my personal experience, but the evidence shows. Here you see, the ARNI reduces the risk of cardiovascular death and heart failure hospitalization and heart failure reduced in person with low BP. Low BP means these patients were having blood pressure in the lower range. All these are all patients, enalapril, here is acute valsartan, systolic BP less than 110. In those, here systolic BP between 110 to 120. These two subgroups they saw. They found a 12% reduction in the risk of cardiovascular death or heart failure hospitalization in patients who have a reduced ejection fraction, even in this BP range when treated with sacubitril valsartan. So even the lower BP range also the benefit is there. Here the ARNI and risk of hypotension, we know the chances of hypotension is there. Here it is see the 0, 15, 30, 45 days. Accordingly, the death after hypotension is an adverse event in patients with sacubitril valsartan, patient with enalapril is found. If the patient have hypotension with the enalapril, chances of death is more. Comparatively, even if the patients with sacubitril valsartan have a hypotension, the survival is better and death is less. So all situations it has been found that sacubitril valsartan is better than enalapril. छोट छोट कनसेसन्स पड़े दी तीन टा एकाथरे कवर ताकू गोटे पर ग्राफ्स consensus point 7. How do we manage hypotension with ARNI? This is very important. You are giving the patient ARNI, patient develop hypotension. What will do? Heart will stop ARNI or do something else. Guideline is there. You must follow this. Heart need to correct the volume and salt depletion. If the patient is hypovolemic, if there is hyponatremia or salt is less, they are able to correct heart. Prior to administration, look at this, correct the volume and salt depletion. In hypovolemic patient, dose of diuretic is likely to downgrade it. The diuretic dose to be reduced. First, you have to reduce the dose of the diuretic. In fragile patient, elderly patient with systolic blood pressure 100-110, lowering the starting dose of sacubitril valsartan. So in such cases, you have to lower the dose of sacubitril valsartan. First, correct this salt and salt, water, electrolyte, reduce the diuretics. Till then you can reduce the dose of acidophilic or sacubitril valsartan. In patients previously with low dose of ACNOARB or naive with ACNOARB, lower starting dose of lower of titration of sacubitril valsartan. As with any other disease, modifying the treatment that have effects on lowering the blood pressure like beta blocker, MRA are to be considered. So that means the dosage of beta blocker and MRA is also to be modified in such situations. So remember, if the patient is on foundational therapy, then patient develop hypotension, do not panic. First you see if salt, some water, fluid, maybe if it is admitted in can be infused. If still remains in hypotension, diuretic is to be reduced. After that, you can reduce the dose of beta blocker and MRA. And if you find ARNI the most beneficial molecule, and till the end, we should not stop ARNI, we should reduce the dose of ARNI, and gradually when the blood pressure picks up, we can continue this. This is very important. It has been seen after the invent of ARNI, after the use of ARNI, many patients are not requiring ICD or CRT. So, opinion of experts, you must give a trial of ARNI before going for ICD or CRT in such patients. Let us see what the evidence says. So, evidence, will introduction of ARNI reduce the need of device therapy in heart failure, reduce ejection fraction? This came here this is what the recommendation says. The type of prevention where it is used, primary prevention or secondary prevention, ICD-CRT I'm telling you. And primary secondary prevention means patient is a survivor of cardiac arrest or patient has improved for ventricular fibrillation, ventricular tachycardia. In such patients, what to do? So an ICD is recommended to reduce the risk of sudden death or cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability and who are expected to survive more than 1 year with good functional status, is class 1A. In primary prevention, there is dilated cardiomyopathy and ischemic heart disease, that is AMI after 40 days. You see, because there are trials, so it should be patient stabilized for 6 weeks or 40 days. There are 2 trials. After that, you can consider giving ICD or CRT. This is again, you see, this is a gap. Another say, see, this is symptomatic heart failure, the symptomatic type 2 deep ARNI and all. Here, not a candidate of CRT ICD. To LV ejection fraction less than 35%, NOH class 2 to 3. If LVEF is less than 30%, even in NOH class 1, then cardiomyopathy, history of BTPF. In patients of LVVB, QRS with 120 to 150 milliseconds can be considered as CRT. If not LVVB, that is RVVB or the non-specific widening of the QRS, this QRS duration should be more than 150 milliseconds. In such situations, only you can consider CRT or CRT. So what is the chances of new onset diabetes after starting ARNI? Is it beneficial in patients with diabetes and non-diabetes? Do they develop diabetes? Let us see what the trial says. This is a clinical presentation management of an in-hospital 90-day outcome of heart failure patients, the Trivandrum heart failure registry. Here, they found 55% of patients were hospitalized for heart failure, they had diabetes. At hospitalization and at discharge, they have seen. So, what they found? The heart failure and diabetes in different studies, other than this study that was 55%. Here in other trials like Paradigm HF, 35% were diabetic, SHIFT 30%, ECO-CRT 41%, and different this about 30 to 40% of patients with heart failure do have diabetes. And how many patients diabetic have heart failure? Here it says different DPP4 trials, SGLT2 trials, GLP1 another trial, about 13 to 25%, 10 to 15%, 14 to 20%. This is about, so you can broadly remember 10 to 20% patients with diabetes may have heart failure as a coincident finding. So this considered ARNI reduces the CV death or heart failure hospitalization, improves the quality of life irrespective of glycemic status. They have seen what is the impact of life? 20% reduction of CV death and 20% reduction in heart failure hospitalization. So irrespective of glycemic status, whether they have controlled diabetes or not, even if it is uncontrolled diabetes or controlled, there is still 20% reduction in cardiovascular death, 20% reduction in heart failure hospitalization. This is the effect of ARNI on glycemic control. You see here the enalapril is the red one and sacubitril valsartan one. The patient, those who take sacubitril valsartan, they have better glycemic control if they are diabetic. So that not only it changes the mean HbA1c and confidence interval in the treatment group. So it has a beneficial effect as regards glycemic control or blood sugar control is concerned in patients with diabetes and heart failure. It has been seen giving OHA and insulin is also less if the patient is taking ARNI. So new use of insulin is 29% lower with ARNI versus enalapril. They may not require ARNI, they may not require insulin. The insulin requirement may be delayed. Fewer patients were started on OHA therapy with ARNI. Those when on ARNI, the starting OHA therapy, may not be required or may be required later. So this has a beneficial effect in patients with diabetes. This is completely a separate category. Till now, what I find the evidences, the benefits are there in heart failure with reduced disease impact. So let us see what are the evidences, what are the trials, what it shows in patients with heart failure with preserved disease impact. As we all know, out of all patients with heart failure, 50% are patients with preserved disease impact and 50% are heart failure with reduced disease impact. So if you do not address the issue of preserved disease impact, we are just ignoring 50% of patients with heart failure. This is a very informative slide where you see the difference is in patients. This is a patient of heart failure with preserved disease impact. They are obese. There may be involvement of the cardiac, pulmonary, liver, renal, visceral adiposity, musculoskeletal system in different ways, and there will be metabolic stress. So the metabolic stress, the aging, cardiac remodeling, ventricular vascular stiffening, sedentary time and again we are discussing because of the risk of serious angioedema, more often in blacks, which is more often in blacks. Early scaling is a direct inhibitor. Here we should not do potassium sparing diabetes. We should be careful. This may lead to increased hyperkalemia, especially renal impairment, diabetes, and hyperaldosteronism. NSAIDs may lead to increase in risk of renal impairment. Lithium increase to lithium toxicity. Birth control pill containing droxiquinone has been found to be not beneficial. What percent of patients with heart failure reduced ejection fraction and preserved ejection fraction will have contraindication to use of ARNI in real world? In the real world data, how many percent of patients with reduced ejection fraction and preserved will have contraindication? How do we manage hyperkalemia with ARNI insufficiency? So very important, because if you see in the real world, around less than 10% of the patients with heart failure will have contraindication to use of ARNI. And in certain situations we have to be careful by starting as conditions were mentioned. And if there is hyperkalemia, hyperpotassium, how to manage? Strict low potassium diet, small dose of loop diuretic that take out the potassium, potassium binding in emergency situation, potassium binding sachets, and combined aspirin nebulization. Nebulization can reduce the potassium. The old is gold, glucose insulin infusion in stubborn cases. So actually glucose insulin infusion make the potassium intracellular. From the extracellular, we go to the intracellular. And this is patiromer is a boon. Patiromer is a drug which can reduce potassium. Now scientists and physicians are contemplating in situations where we are using ARNI and MRA. If we use patiromer, the chances of hyperkalemia will be much less, and patient will get the benefit of both ARNI and MRA if patiromer can use in such situations. Consensus number 14. What would be the impact on lives of patient in case of discontinuation of ARNI? Whether ARNI should be discontinued. What are the situations? If the patient is intolerant to ARNI, then it will have to be discontinued. If the patient develops or hypotension not coming up, definitely will reduce the dose, or if required, it may be discontinued. Other situation comes, ejection fraction improves. Patient improve from heart failure reduced ejection fraction to mid-range or preserved ejection fraction. Then what to do? That will be a million-dollar question. Let us see what the evidence says. So, sacubitril valsartan in daily clinical practice data from prospective study, ARNI withdrawal in patients with heart failure and reduced ejection fraction were independently associated with increased alcohol mortality. If you withdraw ARNI, the chances of deterioration and chances of bad effect is there. So patients who continue with sacubitril valsartan presented an important improvement in functional class LVEF and anti-proBNP level. And this should ARNI be discontinued once LVEF improve, what I was telling, the so-called heart failure with recovered ejection fraction or heart failure with improved ejection fraction subset. You see, this is very informative slide. In patients heart failure preserved ejection fraction, 60 to 90% remain in preserved ejection fraction. 10 to 20% either go to heart failure mid-range ejection fraction or less than 10% go to heart failure reduced gradually deteriorate. With mid-range ejection fraction, mostly they stay in mid-range ejection fraction, but 20 to 30% go to preserved ejection fraction, further improvement, and 10 to 20% can also deteriorate to reduced ejection fraction. In patients who have a reduced ejection fraction, 60 to 80% remain in reduced ejection. However, these 20 to 30% what remain, they can improve to mid-range or improve to preserved ejection fraction. Here mid-range is 40 to 50, preserved is CF more than 50, and reduced is less than 40. If the ejection fraction improves, the improved ejection, recovered ejection fraction, whether are going to continue ARNI or not, what the guideline says. Guideline says in patients with heart failure with improved ejection fraction, after treatment, GTMT should be continued to prevent relapse of heart failure and left ventricular dysfunction, even in patients who may become asymptomatic. Even if the EF improve, even if there is a patient is asymptomatic, we should continue ARNI. Otherwise, there may be chances that there may be development of relapse of heart failure and there may be LV dysfunction. So after this, we will come for the pearls of consensus. These two slides are very important. You must concentrate these two slides. ARNI is molecule of century and is indispensable and superior to ACE inhibitor in reducing the cardiovascular death. Because the sea change in the treatment of heart failure has come after the paradigm heart failure trial in 2014, where ARNI was found to have to reduce relative risk reduction of death and heart failure hospitalization 20% over and above 17% of NLRP. Because this is a trial where ARNI was compared to NLRP. This is not compared to placebo. Many trials, there is an active comparator. Other studies will find the ARNI, other than I say other studies, they will compare to placebo. Placebo means somebody taking 3 drugs, these are guided medicated drugs, plus placebo one arm, other arm is another active drug. Here, 2 arms had active drug. One arm had 10 milligram of NLRP twice daily, and ARNI here 200 milligram twice daily. So over and above 17% benefit of NLRP, there are 20% further benefit. If you take out, if trial would have been compared with placebo, there would have been 37% reduction in the heart failure hospitalization or mortality. That is why there is so much of benefit for the found patient with ARNI. In heart failure reduced ejection fraction and reverses the adverse LV remodeling and improves quality of life. This is very important. Even the studies came up prior to that. We have seen in our practice patients taking ARNI having improvement in quality of life and improvement in ejection fraction. That came late evidences that these are possible. So not only it reduces the mortality, not only it reduces heart failure hospitalization, it improves ejection fraction, improves quality of life. ARNI should be initiated as early as possible in patients with acute decompensated heart failure and de novo heart failure patients. As we know, is what trial shows, in acute decompensated heart failure, once the patient is stabilized in hospital with the diuretics, then ARNI should be started pre-discharge and should be optimized on OPD basis. And de novo heart failure, ARNI should be started to prevent decompensation, to prevent further deterioration. ARNI should be given for at least 3 to 6 months along with other foundational therapy for heart failure reduced ejection and LVEF reassessed with echo and CMRI, cardiac MRI, before the considering ICD or CRT in such patients. So what we were discussing earlier patients after AMI 42 days, where EF remains still less than 35, dilated cardiomyopathy with wide QRS, patient not improving standard care therapy, we are considering putting ICD or CRT. Now, the guideline says without giving a trial of ARNI, one should not advise ICD or CRT, because they have seen after the use of ARNI, many patients have not needed ICD or CRT, they have improved. ARNI should be used in all patients with heart failure preserved ejection fraction up to LVEF 57 to 60%, along with SGLT2 inhibitor to reduce heart failure hospitalization and quality of life. As we saw, the studies showed there is reduction in heart failure hospitalization, improvement in quality of life, though it has not shown to be beneficial in reducing the mortality and improving the survival. Indicated as time and again we are discussing, because the risk of serious angioedema, more often in blacks, which is more often in blacks, unless can be the direct inhibitor, here should not be. Potassium sparing diuretics, we should be careful. This may lead to increased hyperkalemia, especially renal impairment, diabetes and hyperaldosteronism. NSAIDs may lead to increase in risk of renal impairment. Lithium, increase to lithium toxicity. Birth control pill containing droxiticare has been found to be not beneficial. Because if you see in the real world, around less than 10% of the patients heart failure will have contraindication to use of ARNI. And in certain situations we have to be careful by starting as conditions were mentioned. And if there is hyperkalemia, hyperpotassium, how to manage? Strict low potassium diet, small dose of loop diuretic that take out the potassium, potassium binding in emergency situation, potassium binding sachets, and combined aspirin nebulization. Nebulization can reduce the potassium. The old is gold glucose insulin infusion in stubborn cases. So actually glucose insulin infusion make the potassium intracellular. From the extracellular we go to the intracellular. And this patiromer is a boon. Patiromer is a drug which can reduce potassium. Now scientists and physicians are contemplating in situations where we are using ARNI and MRA. If we use patiromer, the chances of hyperkalemia will be much less, and patient will get the benefit of both ARNI and MRA if patiromer can use in such situations. If the patient is intolerant to ARNI, then it will have to discontinue. If the patient develops or hypotension not coming up, definitely will reduce the dose, or if required, it may be discontinued. Other situation comes, ejection fraction improves. Patient improve from heart failure reduced ejection fraction to mid-range or preserved ejection fraction. Then what to do? That will be $1 million question. Let us see what the evidence says. To sacubitril valsartan in daily clinical practice data from prospective study, ARNI withdrawal in patients with heart failure and reduced ejection fraction were independently associated with increased alcohol mortality. If you withdraw ARNI, the chances of deterioration and chances of bad effect is there. So patients who continue with sacubitril valsartan presented an important improvement in functional class LVEF and anti-proBNP level. See, this is very informative slide. In patients heart failure preserved ejection fraction, 60 to 90% remain in preserved ejection fraction. 10 to 20% either go to heart failure mid-range ejection fraction or less than 10% go to have the reduced gradually deteriorate. With mid-range ejection fraction, mostly they stay in mid-range ejection fraction, but 20 to 30% go to preserved ejection fraction, further improvement, and 10 to 20% can also deteriorate to reduced ejection fraction. In patients who have a reduced ejection fraction, 60 to 80% remain in reduced ejection. However, these 20 to 30% what remain, they can improve to mid-range or improve to preserved ejection fraction. Here mid-range is 40 to 50, preserved is CF more than 50, and reduced is less than 40. If the ejection fraction improves, the improved ejection, recovered ejection fraction, whether are going to continue ARNI or not, what the guideline says. Guideline says in patients with heart failure with improved ejection fraction, after treatment, GTMT should be continued to prevent relapse of heart failure and left ventricular dysfunction, even in patients who may become asymptomatic. Even if the EF improve, even if there is a patient is asymptomatic, we should continue ARNI. Otherwise, there may be chances that there may be development of relapse of heart failure and there may be LV dysfunction. So after this, we will come for the pearls of consensus. These two slides are very important. You must concentrate these two slides. ARNI is molecule of century and is indispensable and superior to ACE inhibitor in reducing the cardiovascular death, heart failure hospitalization, sudden cardiac death in patients who have reduced ejection fraction. Because the sea change in the treatment of heart failure has come after the paradigm heart failure trial in 2014, where ARNI was found to have to reduce relative risk reduction of death and heart failure hospitalization 20% over and above 17% of NLRP. Because this is a trial where ARNI was compared to NLRP. This is not compared to placebo. Many trials there is an active comparator. Other studies will find the ARNI, other than I say other studies, they will compare to placebo. Placebo means somebody taking 3 drugs, these are guideline medicated drugs, plus placebo one arm, other arm is another active drug. Here, 2 arms had active drug. One arm had 10 milligram of NLRP twice daily, and ARNI here 200 milligram twice daily. So over and above 17% benefit of NLRP, there are 20% further benefit. If you take out if trial would have been compared with placebo, there would have been 37% reduction in the heart failure hospitalization or mortality. That is why there is so much of benefit for the found patient with ARNI. So ARNI also improves left ventricular ejection fraction in heart failure reduced ejection fraction and reverses the adverse LV remodeling and improves quality of life. This is very important. Even the studies came up prior to that. We have seen in our practice patients taking ARNI having improvement in quality of life and improvement in ejection fraction. That came late from the evidences that these are possible. So not only it reduces the mortality, not only it reduces heart failure hospitalization, it improves ejection fraction, improves quality of life. ARNI should be initiated as early as possible in patients with acute decompensated heart failure and de novo heart failure patients. As we know, is what the trial shows, in acute decompensated heart failure, once the patient is stabilized in hospital with the diuretics, then ARNI should be started pre-discharge and should be optimized on OPD basis. And de novo heart failure, ARNI should be started to prevent decompensation, to prevent further deterioration. ARNI should be given for at least 3 to 6 months along with other foundational therapy for heart failure reduced reduction and LVEF reassessed with echo and CMRI, cardiac MRI, before the considering ICD or CRT in such patients. So what we were discussing earlier patients after AMI 42 days EF remains still less than 35, dilated cardiomyopathy with wide QRS, patient not improving standard care therapy, we are considering putting ICD or CRT. Now, the guideline says without giving a trial of ARNI, one should not advise ICD or CRT, because they have seen after the use of ARNI, many patients have not needed ICD or CRT, they have improved. ARNI should be used in all patients with heart rate preserved ejection fraction up to LVA 57 to 60%, along with SGLT2 inhibitor to reduce heart failure hospitalization and quality of life. As we saw, the studies showed there is reduction in heart failure hospitalization, improvement in quality of life, though not, it has not shown to be beneficial in reducing the mortality and improving the survival. Here we come, the drug and devices trial in heart failure with reduced ejection fraction. This is graph you see, the different trials, they started from Valsartan heart failure trial started in 1986, then consensus heart failure reduced, the SOLVE2, AIR, all the things they tried, and now there is a big trial on digoxin, there are Atlas, Rails, CBIS, Merit-HF, beta blocker, Copernicus on beta blocker. There are several trials. This again from 2001 onward, the trial on Valsartan heart failure trials, the rematch, CHARM added, CHARM preserved, seniors, HEAL, the CRT trial, MADIT CRT, HARTMET. There are several trials. In 2014 came the Paradigm heart failure trial. This Paradigm heart failure trial, they have actually changed the scenario of patients' treatment, of patients of heart failure treatment, so that survival improved, quality of life improved. This came a big step forward in the management of heart failure. Let us analyze what is Paradigm HF trial. Paradigm HF or Paradigm heart failure study design. This is a ARNI in patients with heart failure with NYHA class 2 to 4. So class 2 to 4, NYHA class 2 to 4, with left ventricular ejection fraction less than 40%. The primary endpoint was cardiovascular mortality or heart hospitalization for heart failure. How patients are randomized? 8,442 patients, they were single blind active run-in period. They were either given enalapril or sacubitril valsartan. So those who were taking enalapril, they had to discontinue and take 50% of them will continue with enalapril and others will continue sacubitril valsartan. And those who tolerated sacubitril valsartan projected dose, the 200 mg twice daily, they will be included in the study. By that, in 4 weeks, 8,442 patients were enrolled. There is a double-blind treatment period. One group took enalapril 10 mg twice daily, while other group sacubitril valsartan 200 mg twice daily. On top of standard heart failure with reduced ejection fraction therapy. So standard baseline medical management was continued, and over and above, one group take enalapril 10 mg twice daily. The other is sacubitril valsartan 200 mg twice daily. What are the key eligibility criteria? This is very important. This trial we must know in detail, because on this we are coming with different trials. So in and out patients were classified NYHA class 2 to 4 with left ventricular ejection fraction less than or 35%. More than 4 weeks of stable treatment with ACE inhibitor or ARB and beta blocker. They have found BNP or NT-proBNP level were seen, they are found to be elevated. In such patients, what are the exclusion criteria? History of angioedema, history of drug interaction, drug reaction. EGFR less than 30 were excluded from this study. The symptomatic hypotension and patients with BP systolic blood pressure less than 100 mmHg, they were also excluded. the requirement of treatment with both ACE inhibitor and ARNI, serum potassium level more than 5.2 millimole per liter, there was current acute decompensated heart failure and history of severe pulmonary disease. These are the patients they are excluded. But they found this is the largest mortality morbidity trial in patients with heart failure reduced ejection fraction, most geographically diverse trial, patients heart failure reduced ejection fraction, most racially diverse heart failure trial. If you see here, what the address? Cardiovascular death, heart failure hospitalization, overall mortality, that means all cause death. Then heart failure death, death due to heart failure and shorter death. Their main aim was cardiovascular death and heart failure hospitalization. They also addressed overall all cause death, heart failure, death due to heart failure and death due to short cardiac death. So all these points they are found. Blue one is enalapril and maroon is sacubitril valsartan. So there is 20% reduction in cardiovascular death, heart failure hospitalization in patients with sacubitril valsartan group compared to enalapril. The overall mortality reduction of 16%, heart failure death and this is around 21% and death short cardiac death 20%. This is one of the important slides you must see. These are the drugs which is found to reduce the mortality. The mortality is the hardest endpoint. What is the maximum benefit? Is death, prevention of death, the survival benefit. These are the agents: ACE inhibitor, ARNI, beta blocker, aldosterone antagonist, hydrogen nitrate. They have been found to have mortality benefit. This table shows the medical therapy for stage C heart failure reduced ejection fraction, magnitude of benefit demonstrated by randomized controlled trial. And they have taken here the relative risk reduction in mortality. ACE inhibitor is 17%, beta blocker 34%, and aldosterone antagonist 30%, hydrogen nitrate in blacks, they are given in blacks 43%. And number needed to treat for reduction of one mortality in 3 years, in 36 months. But you see, if 6 patients are treated with aldosterone antagonist, they can prevent one death. Whereas that is 7 for hydrogen nitrate, 9 for beta blocker, and ACE inhibitor ARB is 26. So what is the position here? ARNI. ARNI comes relative reduction 20%, and number needed to reduce one death in 3 years is 32, and relative risk reduction is 21%. This NOHA class changes with treatment of sacubitril valsartan. You see, this NOHA class 1 is shown is white. This is maroon is class 2 and black is class 3 and 4. First one is pre-sacubitril valsartan. This is post-sacubitril valsartan. After treatment with sacubitril valsartan, it has been seen an improvement in the NOHA class. The patients with class 2, 3 and 4 are reduced and they have shifted to the class 1. Class 1 increases. So there is improvement in the NOHA class. This has been seen at 30 days. After 30 days of treatment with sacubitril valsartan, a significant improvement in NOHA class was found with 36 patients experiencing improvement by at least one NOHA class category. Before sacubitril valsartan treatment, 8.6% of patients were in NOHA class 1, where after the treatment, the percent of the patients in NOHA class 1 increased to 32.4%. Here, in all subgroup of patients more than 75 years, less than 75 years, EF more than 35, if less than 35, EGFR less than 60, more than 60, systolic BP more than 120, less than 120, NT-proBNP more than 1615 or less than all category patients, there is improvement of ARNI. So ARNI is superior to ACE inhibitor because here ARNI and sacubitril valsartan are compared with enalapril, superior to ACE inhibitor across the subgroup of patients with chronic heart failure with reduced ejection fraction. These are the clinically efficacy in patients with Asian patients. In the paradigm heart failure patient, the number of patients from Asia, they were analyzed. It was found all parts of Asia, East Asia, South Asia, or Southeast Asia, all were found to be beneficial while treated with sacubitril valsartan. This is how we can see the role of sacubitril valsartan in the treatment of heart failure, particularly with ARNI. We should be very clear what is de novo heart failure, what is acute decompensated heart failure, what is de novo heart failure. De novo heart failure, I am telling her, no history of heart failure earlier. This comorbidities like COPD, ischemic heart disease, atrial fibrillation, diabetes, stroke, they are less frequent. And trigger events like cardiac ischemia, valvular incompetence due to acute amine, acute mitral regurgitation, inflammatory or toxic results are required. And a cardiogenic shock and acute pulmonary edema, then with this presentation. And acute hemodynamic derangement followed by LV systolic dysfunction. Whereas acute decompensated heart failure, what is that? This is a patient of chronic heart failure, they go to acute decompensation stage. So these are older population whose baseline status or laboratory findings, they are known history of underlying heart failure. This was a comorbidity associated, ischemic heart disease, COPD, AF, atrial fibrillation, diabetes, stroke, TIA, history of CVG or PCI. And trigger events, medication, the poor compliance to medication, the resistance to medication, if there is infection, diet, like excessive salt intake, cardiovascular complications, interventions like surgery, drugs, etc. And clinical, how they present? They present with dyspnea, orthopnea, lower limb edema, ascites, wet gain. So they were stable patients. They go to acute decompensated phase, decompensated stage. So they become swollen and wet. So pulmonary and systemic vascular congestion occurs, cause LV dysfunction, inappropriate neurological acceleration symptoms, and fluid overload and rediffusion of the fluids.